This video, for anyone who doesn't know who I am, I'm a UK-based consultant audiologist and clinical ear care specialist. I'm also the founder and director of a company called Clearwax. Clearwax are the manufacturers and developers of the wireless eye clearscope endoscope device that we're using to perform and record the procedure. Clearwax also train qualified ear professionals internationally in endoscopic ear care. And if you are based in the UK and you're suffering from a blocked ear and would like to arrange an appointment with one of our Clearwax specialists, please do visit our website, which is www.clearwax.co.uk. This is a very interesting case. A client booked in last week in sheer desperation for help. They've been suffering from severe otalgia. So otalgia is the medical name for earache, and reduced hearing for several weeks in the left ear. They visited a couple of ear specialists on the high street to try and have their ears, the blockage removed. Unfortunately, on both occasions, they weren't able to remove the blockage, and they advised the patient that they felt she had a foreign body in the ear. As a result, the client visited their local walk-in centre. Due to the pandemic, it's a bit difficult for clients to visit their own GP at the moment, depending upon your geographical location in the UK and the local policy on seeing patients face-to-face. However, there are emergency walk-in centres where there's centres which house general practitioners and nurses. They're not your own registered GP or nurse, but they are open to the public in emergencies. Similar to an accident and emergency at your local hospital, but not obviously for life and death cases such as A&E. They attempted to remove it, but said they'd be best actually going to A&E if there is a foreign body. They weren't themselves sure what was causing the blockage. The patient then went to A&E. A&E are not ear specialists, so they're not trained per se to deal with earwax removal blockages, but the patient advised they tried to remove the blockage and it caused them severe pain. So they were advised by accident emergency to request their GP to arrange an outpatient ENT appointment so they can see an ENT specialist, and in the meantime use some earwax drops. That will take months. The patient's friend, who's actually a dentist, came across my YouTube channel and advised the patient to book an appointment with myself, and hence the patient attended. So just thought I'd give you that backdrop, so it's a good place to start. So started off using a Zollner suction probe. I kind of figured really early on that this is not earwax, this is keratosis obturans. Keratosis obturans can have the appearance of earwax. You can see it right now to the untrained eye. So even when I first started, it was very difficult to differentiate between keratosis obturans and earwax because it's got the similar colour, similar complexion. However, the texture of it is completely different. It's springy, it's coiled, it's skins of ribbon that have shedded from the ear canal but hasn't migrated, and this dead skin, eventually it coils up because it's not migrating from the ear, and you get another layer of skin and another layer of skin, and these skins coil and take up a ribbon appearance, and they completely block the ear eventually. And it's such a hard thing to remove because this skin is adhered to the canal wall. You can actually just visually see all the skin ribbons there when I'm removing this using a Jobson horn. You've got different layers, so the fresher layers of skin are lighter in complexion, the darker layers of skin are the skin layers that have been in the ear for a lot longer. So you'll generally find the lighter skin, so the fresher layers of skin around the perimeter, around the outside of the plug, and the darker, older skin layers more in the core and the centre because they've oxidised. So I'm just using a combination of all the micro instruments at my disposal. We're using a bit of suction, we're using forceps, we're using an ear hook, we're using a Jobson horn. It did help that this patient had been using some sodium bicarbonate earwax drops, which is the best type of drops if you have got keratosis obturans. I find that if you use olive oil, which is what I normally recommend to my patients, if you have got dead skin or keratosis obturans, it's not that beneficial to the patient, and it doesn't really make the procedure any easier. Whereas sodium bicarbonate drops for this type of procedure really does help. It helps to loosen the skin adhesions from the ear canal, which is so imperative when you're removing keratosis obturans. So you can just see, just using some forceps at the moment, trying to get a grip, just pulling out these coils of dead skin plugs out of the ear. With cases of keratosis obturans, it can be quite shocking how much debris we remove, and that's because the skin, as it coils, it compresses, which means there's a lot more space in the ear canal than if it was for hard wax, for example. So because these layers of dead skin have compressed and coiled, it's possible to really get a big haul of dead skin plugs out of the ear. You can see this fresher layer of skin, as I've referred to earlier, on the outer perimeter coating the main plug of dead skin in the core. And so, as I said, the fresher layer of skin, it hasn't yet oxidized, so it's white in appearance. With this dead skin keratin that's coiled, it has a lot of kinetic energy, so it's springy. As I said earlier at the beginning of the video, removing keratosis obturans can be quite difficult for that reason, or for two reasons. It's adhered to the canal wall, and it has this springy effect because of all that coil spring, all that kinetic energy. So you're pulling at this, and then it kind of springs back. It coils back inwards. So just using the forceps, another huge plug of dead keratin I removed. Keratosis obturans, because of the skin, if it's been in there for too long, it can become infected and it can start eroding the ear canal itself. And you'll see with this particular patient, she had a widened and eroded annulus region of her ear canal. So the annulus is near the base of the eardrum, so it's deep in the ear, so it's medial. So there's just another big ribbon of dead skin. And it's at the base, so it's at the bottom of the ear canal, on the bony part, and you'll see it's become really widened and exposed. So this patient will now, because of that, get a chronic buildup of dead skin in this kind of cave that's corroded, in this widening and erosion. So when you've got a trench or widening, or as I said, an erosion of the ear canal, it makes it more difficult for skin or earwax to naturally migrate, so it can collect in that crater, which is going to possibly be the case for this patient moving forward. So after the procedure, I've advised the patient to attend annually in the first instance. So we're just near the eardrum now, so it's very difficult to ascertain whereabouts we are in the ear canal because it's all very white, all this dead skin. We don't know whether the region right in the distance is another plug of dead skin, or is it the eardrum and there's some skin attached to it. But I can just see through some of this dead keratin, and I know now that I'm working directly on the eardrum. But the eardrum is completely hidden away by a thick layer of dead keratin. Now it's impossible. I'll just advise you, I don't manage to remove all of this. It was really adhered. However, even at this stage, the patient's symptoms had been completely alleviated. That pain had completely gone. It was almost like a light switch moment. When I removed one of the latter plugs of keratin, instantly they felt relieved of their symptoms. The hearing had come back. It was completely restored. So the idea now, I just want to try and remove as much keratin off the eardrum as safely as possible without causing any injury or trauma to the ear canal or to the eardrum itself. Because we're working deep in the ear, the deeper part of the ear canal is very sensitive. So the inner 2/3 of the ear canal, it's made up of bone and a very thin layer of skin that's lining the bone. That layer of skin is 0.1 millimeters, so it's a very delicate layer of skin. Whereas the outer third, it's a flexible part of the ear canal. It's made up of cartilage and some muscle and fatty tissue, and the skin there is a lot thicker. In fact, it's 10 times thicker. It's about 1 millimeter in thickness. So Just as a general rule of thumb, just so you can understand the ear anatomy, the outer third of the ear canal, it's flexible, it's semi-sensitive, so it means you can put a bit of pressure in there, it's malleable, whereas the inner 2/3, it's non-flexible and it's very sensitive. So whenever we work near to the eardrum and in the inner 2/3, we have to be very gentle. Also, when we work on the eardrum itself, now the eardrum is also, as I said, it's a very thin membrane. It's wafer thin, it's 1 millimeter in thickness. So we've got to be really careful. It's that trade-off. We want to remove as much dead skin and keratin that we can from the ear canal and off the eardrum, but without causing any injury or trauma to the patient. So I'm just on the anterior canal wall, which is the front part of the ear canal. So this is facing towards the patient's nose, with it being the left eardrum and left ear canal. And you can see I'm just gently peeling this off. Again, we're just going to make sure I don't make contact with the bony part of the ear canal, because that can abrase the ear canal, cut into the thin, delicate skin layer, causing infection. This is the annulus region. So this, if you remember earlier, I was saying that the patient's got a widened and eroded annulus, and this is that part, the base of the eardrum. Right dead center of the eardrum, where the hammer bone is, the malleus, there's this hard crusted piece of dead keratin there. You can see I just went towards it there for a moment. And I'm just using a fine end gauge now, and not a standard Zollner suction probe. So a fine end is an extension to the Zollner suction probe. It's like a little needle. We attach it to the end of the Zollner suction probe, and the fine end, it's less traumatic. So if we do come in contact with the eardrum or the ear canal, it's not going to cause as much trauma. And I use it more for precision work. You can see we've got a thick layer of dead keratin there, and it's also a lot less noisy. Suction is very noisy. The noise itself can sometimes cause temporary or even permanent hearing loss. So we've got to be also careful in terms of duration of how long we're in the ear. But with a fine end, it reduces the noise levels, and also it helps to reduce the chance of the caloric effect. So again, just remove the thin layer of dead keratin on the roof of the ear canal there, using the fine end. So the caloric effect is when so the balance of organ, which is, we call that the vestibular system, it's made up of 3 semicircular canals, and they're in the inner ear, and they can be affected by temperature and pressure. When we vacuum the ear, it reduces the temperature of the ear canal, which inhibits the balance organ in this particular ear. So the patient's right ear, the contralateral ear, the opposite ear, we're not performing a procedure in there. So the temperature of that ear is the normal temperature. In this ear, we've actually reduced the ear temperature by suctioning in the ear. So this balance organ, in comparison to the patient's right balance organ, is inhibited. So when we reduce the temperature, it reduces the function of the balance organ. When we increase the temperature, it actually excites the balance organ. So therefore, the brain, this patient's brain, is receiving normal messages from the patient's right ear, but reduced messages from the patient's left organ of balance. Therefore, the brain actually thinks this patient is moving because it's getting these different conflicting messages. However, the patient's not moving. Therefore, the brain is tricked into thinking it's moving, and therefore you can suffer from vertigo. And that's when the eyes try to correct the brain and tell the brain that don't trust the ears are not giving you the correct information, the patient is not moving. Believe me, I know what I'm talking about. I'm overriding my eyes are overriding the balance organ, and people, as a result, suffer from the caloric effect, and it's a horrible sensation where the room violently spins around. People can also feel sick. So the fine end reduces the likelihood of developing the caloric effect. So again, just working on the eardrum, we can see a lot more of the eardrum now. We can see this is the posterior quadrant, so the posterior part of the eardrum is the back part, and is that thick layer of skin. You can see I was gently peeling it directly off the eardrum. You need a really steady hand for that. One false move and we've perforated that patient's eardrum. Again, she's got a thick layer of keratin on the top part of what we call the superior quadrant. So you can separate the eardrum into quadrants, so into four. So you've got the top part, so the north region, which is called the superior quadrant. We've got the south region of the eardrum, which we call the posterior quadrant. You've got the back part of the eardrum to the rear, which is the posterior to the rear, posterior quadrant. And we've got the front quarter of the eardrum, and we call that the anterior. So here we're more centrally on the eardrum, and again, just delicately with the fine end, you can see I'm just slowly trying to peel this off. At this stage, I was reluctant to put any further sodium bicarbonate drops in, because sometimes with the sodium bicarbonate, it can really cause this dead skin to become really thin, and it just tears off in little pieces. The idea is, at this stage, I wanted to see whether I can get a grip onto this dead keratin and peel it off in a thick mass, but it's very difficult. As I said, I'm not going to get all of this out. I'm actually very happy with where we're at with this patient. The patient can completely hear. This remaining piece of dead keratin will naturally shed now, because the dead skin plugs that was previously in front of it and compressed against it is no longer there, which will allow this dead skin to naturally migrate off the eardrum. So I'm just mopping up near the entrance using a normal Zola suction probe. In a moment, I am going to put some sodium bicarbonate drops in just to give it one last go, because I did try my best to peel it without using the drops, because as I said, I wanted it to be in place. I wanted to peel it off in a thick, continuous layer. Remember, this is not stripping wallpaper, guys. So I know some viewers are going to be absolutely fuming that I didn't manage to remove the rest, which is fine. Yeah, I'm just going to do the best I can and do what's right by the patient. So I'm just going back in, just use some sodium bicarbonate drops to see if this could just loosen this last piece of dead skin. That's more anterior now, so the posterior part of the ear canal is completely visible, that's fine. And then sometimes when we use drops, you get some, it does blare up a bit. Again, just kissing this, you can see the eardrum move there. So again, we're going to be really gentle. So as I'm trying to remove this last piece of keratin, the skin, because it is quite embedded and adhered to the eardrum, when I'm pulling this dead keratin off, it's also causing the eardrum to vibrate. So just going to be really gentle here. So just kissing the surface. And I think I've left it as that. So I'm really pleased with what we've done. That's all the dead skin plugs on a tissue, all the instrumentation we use. There's the sodium bicarbonate drops also that I used during the procedure. Now we weighed this as well, guys. Or you can imagine that 571 milligrams of dead skin blocked in your ear. That's a tremendous amount of dead skin. Patient felt a lot lighter after the procedure. I hope you enjoyed that video, guys. I hope you're all keeping well and safe, and hopefully I'll upload some new videos during the course of the week. Take care, bye.